Hello and welcome to today's ISNTD Connect webinar. My name is Marianne Comperet and I'm speaking from the International Society for Neglected Tropical Diseases based here in London. We've put on this series of webinars as a little way to help professionals and researchers in the fields of tropical diseases and public health remain connected while many workplaces, laboratories and universities were closed. And it's been a real pleasure over the last 8 weeks now to discuss a huge range of topics and diseases in infectious and tropical health. Today, we're moving on to a new condition. Haven't spoken about this before as part of this series, and we will be looking at snakebite envenoming. And possibly one of the most neglected diseases within neglected diseases. Despite affecting over 4.5 million individuals yearly, leading often to death, but also in disability, long-term disability, emotional and financial breakdown. Sadly, efforts to tackle snakebite and snakebite envenoming have often remained inadequate or very fragmented, which has left research in this field, as well as data, pretty scarce. And overall, this also means that this remains a huge threat to some of the world's poorest and most vulnerable individuals. So it's our pleasure today to welcome from Health Action International, our two speakers today, Gaby Ooms and Benjamin Waldmann. Hello.
Hi.
Hi. And Gaby Ooms, you are research manager at HAI International, and Ben, you are snakebite project manager with HAI, and we're thrilled today to have you participate, and I'm really happy to welcome you, as you will be going part of the way towards bridging the gap in the research and the understanding of snakebite care provision. So with no further ado, I will hand over to you to start your presentation. Just before we move on to that, I'd like to say a quick hello to some of our attendees, well, actually to all of you, but also on the chat function, we've got here Dora Johnson, hello, Stephen Maud, hi, Janika van Oorschot, nice to see you here, Amadou Wurijalu, WHO TDR Fellow from the Gambia, so lovely to see all of you connecting here today. And so with no further ado, I'll hand over to you, Gaby and Ben, and we'll meet up in a few minutes after the presentation to take any questions and comments from the attendees. Over to you. Thank you.
Yeah, thank you, Marianne, so much for the introductions, and thank you to ISNTD for having us here today and giving us the opportunity to share some of our work we're doing on snakebite. I'm gonna start the presentation. Let's see. Yeah. So thank you everyone as well for tuning in to listen to Ben and me talk about the work we at Health Action International are doing on snakebite. We've been specifically working in Kenya, Uganda and Zambia in country, as well as doing some work globally. So first of all, I would like to thank my colleagues at HAI, who we worked with together on the research as well as throughout the whole project. And we would also specifically like to thank our in-country partners, Dorothy Okemo, Dennis Kibera, and Leo Kalioka, who helped us with the data collection. And we also want to thank their data collection team for supporting in this. Just a small declaration that we always make is that Health Action International does not take funding from the pharmaceutical industry. So Marianne already told you a bit about snakebite and the problem it means for quite a few people in the world. And I'll just go into it a bit more to give a bit more of a background on why we're working on snakebite specifically. So it is estimated that annually there are 5.4 million snake bites, and of this 2.7 million are envenomings. Of these envenomings, 81,000 to 138,000 end up in deaths, and 400,000 cause disabilities. When we look at the problem more specifically in sub-Saharan Africa, it is estimated that there's 314,000 envenomings, causing 7,000 to 32,000 deaths, and 5,900 to 14,600 amputations. As you can see here is that there's quite a big range in this number of deaths and envenomings, but also amputations and disabilities. And this is because there is quite a big gap in data on snakebite, and it's believed that there's an under reporting of 70%. This is because a lot of people who are bitten by snakes never make it to the health facility. And that is also why deaths and disabilities and envenomings are not recorded properly. So who are the people that are affected mostly by snake bites? Research has shown that about 97% of snakebite deaths occur in rural areas. And often the people who are bitten are those dependent on outdoor activities for livelihood. And these activities include, for example, farming, herding, and fishing, things like that. Those who are bitten are also often in the age category 10 to 30 years, and those are the most economically productive people in the community. And the reason why they're most often bitten is because they're those who are often working on the land or who are doing things outside. So it also makes sense that they are more likely to be bitten. When people are bitten, they often face barriers trying to access proper treatment. First of all, because they have difficulties accessing health facilities. And even if they make it to health facilities, it's difficult for them to receive the appropriate treatment. For example, a study has shown that there's only 2.5% of the needed treatment available in sub-Saharan Africa. And when antivenom is available, in the rare cases that it is, it's often very expensive, too expensive for someone who's been bitten by a snake to afford. And antivenoms are also snake and region specific. So if you have an antivenom available at a health facility that's meant for a snake from India, but you're in sub-Saharan Africa somewhere where they don't have the snake, the antivenom is also not likely to work for that person who's been bitten by a totally different snake. So this is just a short background on what the situation is like in sub-Saharan Africa. And another problem that many countries and governments are facing when they're trying to develop policies next to the lack of resources that they have to try to take action to improve the snakebite situation. There's also often a lack of evidence on the epidemiology burden and response to snakebite in their own countries. So it's also very difficult for them to know what exactly they need to improve the situation. So to try to help governments to take proper action, we are trying to contribute to evidence on a country-specific snakebite burden to help them develop these policies that will help improve the situation. So as part of the research we've done research in health facilities, and the research I will be telling you about today try to identify snakebite patient profiles, healthcare workers' knowledge, and health facilities' capacity to treat snakebite in Kenya, Uganda, and Zambia. So as I said, we did 2 studies to try to identify these variables. One was a health facility survey amongst healthcare workers. And this consisted of 33 questions in which we asked the healthcare workers on patient profiles about healthcare workers' knowledge, so their own knowledge, but also knowledge of fellow healthcare workers, and also about the facility treatment capacity. The second research we've done was on commodities, and this is based on the WHO high methodology titled Measuring Medicine Prices, Availability, Affordability, and Price Components. So far, we've done this research in Uganda and Zambia, and we're planning to do the research this year in Kenya as well. but due to the current COVID-19 situation, it's been postponed. And for this research, we looked at 49 commodities. This included antivenom, but also antibiotics, analgesics, antihistamines, fluids, and medical devices. And we measured the availability, price, affordability, and stockouts at facilities throughout the country. So I'll tell you a bit more about the sampling we use. So the sampling for both these studies is based on the WHO high methodology. So in that methodology, you select 6 regions. In this case, we selected both snakebite endemic and non-endemic areas. And in each region, we then selected 24 facilities. And these facilities were categorized based on public, private, and mission sector, and urban and rural areas. So this is an overview of the health facilities that we've surveyed in the countries. And here you can see that for the first research, we've done it in both Kenya, Uganda, and Zambia. And the commodities research has been done in Uganda and Zambia so far. For the commodities research, you can see for Zambia that almost all the facilities are in the public sector. And unfortunately, this is because just in general, there's a lot more public sector facilities in Zambia. And during this research, it was difficult for us to find private and mission facilities in the first place, and secondly, for them to participate in the research. So in the end, I'm only going to present the public sector data for the commodities research, but we'll get back to that later. Okay, so let's move on to the findings. And I'll first share the findings from the health facility questionnaire, where we asked the perceptions of the healthcare workers on the different questions on the patient profiles, but also about their knowledge and about the treatment capacity of the health facility. So one of the first questions that we asked the healthcare workers was about number of snake bites that the health facility recorded. And we only wanted to know this information if they kept track of the actual snake bites that the facility saw. So in Uganda, we asked that for a 6-month period. And in those 6 months, 140 facilities recorded 593 snake bites. In Kenya and Zambia, we decided to look at 12 months to also keep track of maybe if there's variances in months due to different circumstances. And then we saw that there were 801 snake bites recorded in 108 facilities in Kenya and 875 snake bites in 97 facilities in Zambia. If you look at this graph below, it's based on the question that we asked the healthcare workers when they believed that they saw most snakebite cases. So in what month were they seeing more snakebite cases? And if you look at the graph, you can see a pattern for Uganda and Zambia, where some months have an increase. In Kenya, you don't really see a pattern. So I think it's more interesting now to look at Uganda and Zambia. So for Uganda, if you look closely, you can see an increase in snakebite cases according to the healthcare workers in April, May, and June, as well as in October, November, and December. And interestingly enough, this is in line with when the rainy season in Uganda occurs. A similar finding was found in Zambia, and here you can really see the differences in the perceptions of the healthcare workers, because November, December, and January really go up in when healthcare workers believe there's more snakebite cases compared to the other months. And again, this is in line with the rainy season in Zambia. Interesting is that research done in Costa Rica also showed that there was an increase in snake bites in the rainy season. So this is in line with that research as well. In Kenya, we also asked healthcare workers about the commonly bitten body parts. More than 80% of them mentioned legs. The legs were very commonly bitten, followed by feet, which was mentioned by about a third of the healthcare workers, Then 27.7% mentioned hand and the fingers, and about 18% mentioned the arms. I think it's not surprising that none of the healthcare workers mentioned the back or stomach, and less than 1% mentioned the head, because I think that's just more difficult and less likely to be bitten. So this is quite a full slide, and this is based on 2 questions on the ratio of male to female who's more likely to be bitten, as well as the activity that was most commonly performed when a snakebite patient was bitten by a snake. So if you look at the male to female ratio, you can see that in Kenya, about 45% of healthcare workers believed that there was no difference. So males and females were likely to be bitten. In Uganda and Zambia, this was said by about 36% of healthcare workers. Then, interestingly enough, in Uganda, the same number of healthcare workers believed that males were more likely to be bitten as females. While when in Kenya and Zambia, healthcare workers didn't believe that the male to female ratio was similar, they were more likely to believe that males were more likely to be bitten. But I think if you look at like these numbers and these percentages, I think we can conclude that in general, healthcare workers didn't really see a difference between male and female patients who were bitten. Then when we look at the activity that was most often performed when people were bitten by snakes, in all 3 countries, farming was most commonly mentioned. In Uganda, it was even mentioned by more than 75% of healthcare workers. Then in Uganda and Zambia, it was followed by walking. So just walking outside, not doing anything specifically. This was mentioned by almost 60% of healthcare workers in Zambia. In Kenya, this was not the second most commonly mentioned activity. It was actually herding, which was mentioned by about 1/3 of the healthcare workers. Another interesting thing, I think, is that in Kenya and Zambia, healthcare workers also commonly mentioned collecting firewood, while in Uganda, about 20% of healthcare workers mentioned playing. So this specifically applies to children. And that's a nice bridge to our next slide. And here you can see what the healthcare workers believe was the most common age for people who were bitten. In Uganda, Zambia, and Kenya, the most commonly chosen age category was 20 to 30. In Kenya, it was 19 to 30, but that's more or less the same. In Uganda and Zambia, then the second most commonly mentioned age group was 10 to 20 years, while in Kenya, it was 31 to 45 years. But when you look at both these graphs, you can again see that it's quite similar to what has been shown in other countries, where it's believed that those aged 10 to 30 years are most likely to be bitten. And again, this is in line with the people being in the most productive part of the population. And you can see that in Uganda, Zambia, and Kenya, healthcare workers believe this is the case as well. We also wanted to know a bit about what healthcare workers knew about snakebite treatment. So one of the questions we asked was if they had received training on snakebite management or not. And as you can see here, it was very uncommon that healthcare workers had received training on snakebite management. Zambia had the highest number, with 16.5% of healthcare workers having received any training. In Uganda, it was as low as 8.3%. We also asked their a question about if they felt they had the knowledge to treat snakebite, regardless of if they had training or not. The responses were a bit more positive here, but it was still quite low. For example, especially in Kenya's mission sector, where only 16.7% of the healthcare workers believed they had the knowledge to treat snakebite. In Uganda's public sector, It was also quite low, less than 30%. And it's interesting to see that in the private admission sector, it was a lot higher, almost twice as high at around 60 to 65%. So here you can also see that there's quite something still to be done about knowledge and training on snakebite. Then when we asked the healthcare workers on their perceptions on the availability of equipment and medicines that are needed to treat snakebite, they were quite negative as well. In Zambia, almost 70% of the healthcare workers responded that no, the health facility did not have the proper equipment and medicine available. And in Kenya and Uganda, it was even higher, between 75 and 80%. Another interesting question we asked in Uganda and Zambia was about the effect antivenom treatment had on the health outcomes of snakebite patients. And in Uganda, almost 40% of the healthcare workers believed antivenom had a negative effect. While in Zambia, almost 60% of the healthcare workers were unsure of the effects of antivenom. And I think this is an indication of at least partly the lack of knowledge of healthcare workers on the use of antivenom, and that's probably because it's not available at their facility, so they're not sure how it might work. But it might also be the consequence of having antivenom available that might not be of good quality. This is also dangerous for the health of the patient, but it might also be a consequence of having the wrong antivenom available at the facility. So, for example, having an antivenom that's meant for an Indian snake being used on someone who's been bitten by an African snake, and it's very likely then that it doesn't work, and it can even have an adverse effect on the health of the patient. So the type of treatment that's provided at the health facilities when they see a snakebite patient is shown in this graph. As you can see, a lot of the health facilities provide supportive treatment. So this consists of painkillers, of fluids, but also of antibiotics and antihistamines. Many health facilities also refer patients onto another health facility, probably a higher level facility. Probably because they don't have antivenom available. So if the patient is really in need of antivenom, they have to refer them on to another health facility. I think what's interesting to see in this graph as well is that Kenya seems to have more antivenom available at health facilities, as almost 40% of healthcare workers in the public sector mentioned the use of antivenom in the treatment of snakebite patients at their facility. While in Zambia, it was mentioned by about 6% of healthcare workers. Another interesting thing here that I want to quickly mention is the use of traditional treatment still seems to be part of the treatment provided at some facilities as well. For example, in Zambia, it was about 15% of healthcare workers who mentioned traditional treatment. And this can be, for example, black stones or tourniquets or cutting the wound. And okay, so this is the last question that was asked in the healthcare health facility questionnaire, and it's about complications that were commonly observed in Kenya. The most commonly observed complication was swelling, followed by pain at the site of bite and cellulitis. But as you can see, respiratory distress and gangrene were also still mentioned by about 20% of the healthcare workers as being commonly observed. So now moving on to the research on availability, affordability, and stockouts of the commodities. I quickly saw a question come by about asking why we've not done the research in Kenya. So it was on the planning to do it in April, actually, but due to the COVID-19 situation and the lockdown and not being able to move around, and the facilities, of course, being very busy already, the research has been postponed, and we hope to do it sometime this year when it's possible again. So the research is still in the planning, but of course we have to be sensitive to the situation right now. So when we looked at the 49 commodities that we surveyed, we saw that in general, the overall availability of these commodities was quite low in the 3 sectors in Uganda, as well as in the public sector in Zambia. As you can see here, in Uganda's public sector, the average availability was 34.7%. In Zambia, it was even a little bit lower at 29.4%. In the private admission sectors in Uganda, it was a bit higher at 45% more or less. But when you keep in mind that the WHO target is to have an 80% availability at facilities of commodities, it's almost still at half of what the target is. So yeah, the availability is very low for the commodities. Here, let's take a look at the availability of some of the specific commodities. And I think what we're all very interested in is the availability of antivenom. As you can see here, I've shared 2 percentages of antivenom in the public sectors. The first one is the availability of antivenom at all the facilities that we surveyed. So also lower level and higher level facilities. When we look at that, then availability is very low at 4% in Uganda's public sector and 12% in Zambia's public sector. When we did another analysis and only looked at higher level facilities, so in Uganda, that's health centers 4 and up, and in Zambia, that was district hospitals and up. The availability increases slightly in Uganda to 10%. And it increases to 47% in Zambia. And you think, well, 47%, that's quite a lot higher than this 12% already. But when you take into account that district hospitals are found in urban areas and a lot of people are bitten in rural areas, it will take them a very long time probably to get to the health facility, to the district hospital. And then if they get there and there's a 50% chance that antivenom is not available, and that they might have to go to another district hospital or to another even higher level hospital. It's a very big possibility that it will take them quite a lot more time to get there. And this time might mean the difference between life and death if you've been bitten by a snake. So it's crucial that availability of antivenom has to be higher. When you look at the private admission sector's availability in Uganda, this is the availability at higher level facilities. So starting at health centers 4, you can see it's very low. I mean, it's not available in the mission sector at all, and it's only available in 2% of the private sector facilities. Let's have a look, for example, at epinephrine. Epinephrine is used to treat anaphylactic reactions, and anaphylactic reactions can occur when you inject a patient with antivenom. You can see that availability of epinephrine is also very low across the sectors in Uganda and also in Zambia's public sector. Highest was found in Uganda's public sector at 30%, lowest in Zambia at 6%. I think this really shows again, I mean, it has to be 80% availability, and it's very far from that. Also, when we look at morphine, morphine was only surveyed at higher level facilities again, because this is according to the essential medicine list that says morphine has to be available starting at health centers 4 and up and starting at district hospitals and up. You can see here that morphine was unavailable at all health facilities in Zambia and only available at 14% of public sector facilities in Uganda. Let's move to the next one so I'm not talking too long. Here are just a few of the medical equipments that we also surveyed. I think it's interesting to see that some had quite a good availability. For example, there's syringes in both countries had more than 80% availability. But I also think it's interesting that bandages had a quite low availability in Uganda, especially in the public and private sector. But even in the mission sector, it was only 75%, while in Zambia, it was 83%. And you can also see that the more specialist medical equipment had a lot lower availability as well. So the oral airway, the resuscitator, and the oxygen cylinder. Yeah, so another part of the commodities research was looking at stockouts. So stockouts were measured over a 6-month period. So we asked if there was a stock out in the previous 6 months, and if a stock out occurred, how many days did this stock out last? As you can see here on this slide, stock outs were quite common in the public sectors in Uganda and Zambia. The commodities experienced a stock out at, on average, 27.3% of public facilities in Uganda and 20.5% of public facilities in Zambia. And this ranged from 0% for some commodities, but to also 100% for other commodities. The mission sector in Uganda was doing better, with an average of 5.5% of facilities experienced stockouts for the commodities, and with a range of 0% to 50%. When we looked at stockout days, so we looked at the average stockout days per month. In the public sector, it was again quite high. Uganda, it lasted 10 days per month. In Zambia, it lasted a week per month. In the mission sector, it was again slightly lower, with an average of 3 days of stockouts per month for the commodities. And just quickly go into the last part of this commodity survey, which looked at affordability of the commodities. And affordability was calculated by finding the price of the commodity, the unit price, and then looking at how much you need for one treatment regimen. For example, for antivenom, we only looked at 1 vial, but for other medicines, you might need 6 tablets. So, for example, for codeine, or 30 tablets. So we're just looking at what one treatment regimen would be. And then we compared this to the wage of a lowest paid government worker. And this is according to the guidelines of the WHO to see when a commodity is affordable or not. So when a commodity costs more than a day's wage for a lowest paid government worker, it is considered unaffordable. So in Zambia, since we only surveyed public sector facilities, and commodities are for free in the public sector, all commodities were considered affordable there. In the public and mission sectors of Uganda, all commodities were also affordable, as they cost less than a day's wage for a lowest paid government worker. However, in the private sector in Uganda, there were 4 commodities that are considered unaffordable. The most seriously unaffordable commodity is antivenom. 1 vial of antivenom costs almost 72 days for a lowest paid government worker. I mean, when you take into account that sometimes you need more than just 1 vial to treat the snakebite, and 72 days is already so expensive for just to pay. You can imagine that what happens when you have to pay, for example, for 5 or even 10 vials of antivenom. Tetanus, antitoxin, and codeine were also considered unaffordable, costing almost 10 days for a lowest paid government worker, and amoxicillin costs about 1.76 days. So I think I've thrown a lot of information and a lot of results and findings at you. I hope it wasn't too much and that you could keep track a little bit of it. But just to be sure, I can share a short summary with you. So what we found in the research that we've done is that snake bites most often affect farmers aged 20 to 30 years, and it doesn't really discriminate between males or females. It seems that they're both is likely to be bitten. There's also a lack of training and knowledge among healthcare workers, and there's a lack of equipment and medicines available at healthcare facilities to properly treat snakebite. Stockouts also seem to be common in both Uganda and Zambia, and antivenom is very expensive and unaffordable in Uganda's private sector. So what needs to be done based on what we found in this research is we need to improve the knowledge of healthcare workers on how to treat snakebite. So do in-house training, but also include snakebite management in medical curricula. And we need to ensure that commodities to properly treat snakebite are available and affordable in health facilities. And for that, we need to ensure that surveillance and reporting systems are in place and that they work properly. I think that was all that I was going to share with you today. I'll give the word to Ben, who will tell you more about how we're using this kind of research in the work we do at HI. Thank you.
Thank you very much, Gaby. I'll just, I've seen some fantastic questions being asked, so I'll just quickly swim through a couple of slides just to give some wider context on our program. First of all, I must speak about the global advocacy and our role within that. So really how snakebite has become a much higher profile and now neglected tropical disease started back in 2015 when the Global Snakebite Initiative, who are a group of experts in the space and scientists, came together for a retreat in Cambridge, which is when we also went and joined forces really to look to put snakebite back on the global health agenda. So that followed by a side event which was led by the Costa Rican permanent mission and civil society to drive forward snakebite at the WHO and at the World Health Assembly. We received funding from the Dutch government thereafter to start doing work in country, so in Kenya, Uganda and Zambia, on the research, as Gaby alluded to. Following that, we provide some technical support so that a dossier could be submitted to the NTD Scientific and Technical Advisory Group, which subsequently recognized snakebite as a Category A neglected tropical disease in 2017. 2018, we saw member states vote and pass a resolution which saw that really the global health community are now seeing snakebite as a priority neglected tropical disease. And following that, the WHO, with their new mandate just last year, released a global strategy roadmap, which is available to see on the WHO website. So now really it's about the research and other aspects of work in different areas and really about country level implementation. So I think it's very important to just cover some of those aspects and what's really happened on the global level for snakebite. Our project, so of course the data collection is a key part of that, and with the health facility research, of course we also do community level research. So at the moment we've been compiling, up until now at least, when we've suspended, we've been compiling household surveys which looks at all different aspects of snakebite at a community level and the community response. So things like the effectiveness, the types of traditional methods used, how many people are bitten in communities, and different behaviours for seeking health services, which of course is all really important, as we saw at the beginning of the presentation, that we can see 60, 70, 80% are underreporting for snake bites, and the majority of people are not making it from communities to health facilities at all. So that evidence base is really crucial, and that's our sort of capacity development that we work on. In addition to that, we also do community education. We provide tools, and as you saw from the presentation, it's so integral. The majority of healthcare workers are not receiving any training at all. So part of our program is really building the capacity based upon the research to those areas where there is a snakebite problem, and provide more support and capacity for frontline healthcare workers. It's very important for a multi-stakeholder platform, and that we bring different people together in each country to really discuss evidence, whether it's data collection and the research we discussed, or other things, that there is a platform there, a space for civil society, for ministries of health, for experts, for healthcare workers, all different people involved in snakebite to come together to discuss these things and generate evidence-based advocacy. And from there, our program really looks to build policy recommendations and work with ministries of health so that we can develop comprehensive policy changes for snakebite. And I just want to really commend actually the ministries of health in Uganda, Kenya and Zambia. Throughout the research and throughout the work that we've done in those countries, we've seen, strengthening of surveillance. We've seen, development of task forces. We've seen the integration of some of our community materials, clinical guidelines, and also a national strategy which has been in the process of being developed in Uganda with our partners HEPS Uganda, which really looks to bring together all of the different actions, policy interventions which are required to really treat and manage and prevent snake bites on a national level. So we're really excited that that goes to the next level and we get a clear policy strategy in place which can be contextualized to other countries and support other efforts. So just going quickly back to the WHO roadmap, we're fully aligned our program with the work that the WHO does, and we very much value a position as a partner for them in the roadmap and provide technical guidance support to the work that they do. The WHO have been putting together an advisory group which supports sort of implementation efforts. And there's 4 pillars of the roadmap. I'd definitely recommend to go to the WHO website and look at the fantastic report. It focuses on 4 pillars, one around treatments, one around community engagement, one around health systems, and another around partnerships and resources. And so, together these 4 pillars aim to reduce snakebite deaths and disabilities by 50% by 2030. And all of the work that we do, our work in countries and intervention, is really working towards those same goals and objectives. And community engagement is a key pillar through the research and the other interventions that we provide of our work in country. Final slide, I'm just going to mention about, given that the time that we're in and the importance of what's happening at the moment, not just for snakebite, but on a global health basis, we're starting to look more about, what are the repercussions for snakebite and COVID-19? What are we seeing so far? And at least from our perspective, since we've stopped research for now, we expect that there's more of a status quo, that snake bites won't be necessarily really affected by COVID-19, but more by seasonal variations for snake bite. And of course, we saw from some of the slides there that in Kenya, Uganda and Zambia, there are different times within the year where there are a surge of snake bite cases. So I think that that's more prevalent rather than maybe aspects of COVID-19, for example, lockdowns or social distancing, which may in the short term bring down some snake bites, but I don't think it's going to affect snake bite generally. I think it's more a problem in itself. And of course, the majority of snake bites victims, as Gaby alluded to, are farmers. And of course, farmers are absolutely integral at this time, to be providing support to the rest of the country in the agriculture work that they do. So they're still going to be affected by snake bites. We think linkages with snake bite, we've not seen so many, and I think that one interesting thing we saw in India was a link between the use of ventilators, and we saw with some of the commodities that Gaby mentioned, and the use of respiratory distress and respiratory complications from neurotoxic snake bites could mean that more ventilators available for COVID-19 after the pandemic could be an integral part of snake bite management. So that's quite an interesting link as well to be looking at more. But I think it's key that we really need more insights from the ground, from endemic communities, to understand what's really going on the ground in these times with the changes that have happened. And we'll look to really, in the coming weeks and months, actually showcase those voices a bit more and bring them to the global fora so we can understand more about the linkages and what's really happening for snakebite. For us, we're really focusing on prevention measures at the moment. Of course, we don't want to, research and a lot of activities have stopped, and we don't want to be mixing messages when, of course, it's very important that ministries of health focus on COVID-19. but I think it's very important that communities themselves are still given some support, and that's why our messaging is focusing more on prevention, because if we can prevent snake bites, particularly through some of the community education materials that you see on the slide, at least we're doing some sort of support until we can start scaling up our interventions again, hopefully when COVID-19 reduces. And I think that I'm just going to finish on, in the current context, how important community engagement is. Of course, it's a key pillar of the WHO's roadmap strategy. But I think in the current context for COVID-19, but also moving out of post-COVID-19 landscape, I think it's a fantastic opportunity for ministries of health to start investing more broader into strong community engagement systems, that are adaptable for COVID-19, for pandemics, but also for things like snakebite, which are not eradicable, which are going to be staying here, and but can be controlled, can be prevented, and can be treated. And so I think that that's a really integral part. And I think the snakebite community, it's really important that we start to build better understanding of pockets of best practice, because we do see that snake bites are being controlled and managed in parts locally around the world, and we need to really bring that together into a more coherent policy document to support ministries of health, to really provide adequate, wider contextualized community engagement strategies. So that's all I'll say, and I'll leave it there to answer some questions for Gaby and I.
Gaby and Ben, thank you so much for this really comprehensive presentation. You married exactly what you were discussing within the presentation. That is an increase in the data and the surveillance available, but also kind of mobilizing a lot of voices to, on a policy level, bring together all these issues. So thank you very much for that. And while you were presenting, we've had actually a very active chat. So there are lots of questions there for you, lots of comments, and I believe a huge amount of expertise and experience among the attendees. So that's fantastic, and thank you everyone for being so engaged. That's a real testament to the snakebite community, for sure. And perhaps one of the first things that we thought we might discuss briefly, based on your experience out on the field. We had a question here, a comment from Evan Lee. You did touch upon this slightly during the presentation, but Evan was wondering, talking about the underreporting of snake bites. So how much did you feel was the magnitude of underreporting of snake bite? And also, did you ask about care-seeking behavior outside of health facilities, for example, traditional healers, which could contribute to the underreporting? And kind of looking a bit more broadly at that, what might be some of the strategies or approaches that you would recommend in terms of that community engagement you were mentioning?
Yeah, I can answer the part about the reporting. It's difficult to say only looking at the health facility research we've done, but we're also doing community research at the moment. So we're going into communities to ask community members about if they have personal experience with snakebite, or if they know a family member who has been bitten by a snake, or if they know anyone in the community who's been bitten by a snake. At the moment, we're still in the process of data collection, but from the data that's coming in, and this is research we're doing in Kenya, we can see that it's quite a big problem, at least in the snakebite endemic areas, where it's about 10% of people who we surveyed have been bitten by a snake themselves, and about 30 to 40% know someone in the community who has been bitten. So I think if you compare this with the exact numbers of snakebite patients who have been reported in the health facilities, I think you can see that it's also quite a big underestimation of the snakebite cases in the 3 countries where we've done the research. regarding the question about if we asked healthcare workers about the use of traditional healing, we also did include a question about if they believe patients first went to a traditional healer before they went to a health facility. And there were quite a few healthcare workers who did believe this. And we've also done focus group discussions in communities in Kenya, where we specifically included people who were bitten by a snake or who knew someone who was bitten by a snake. And in those focus group discussions, we also hear a lot about how patients first use first aid, such as black stones and tourniquets, or cutting the wound, or putting tobacco on wounds, or making people drink tobacco to vomit so they get rid of the venom. And these are all traditional methods which are not scientifically proven to work. And they use these first aid traditional methods before they go to health facilities. And also in the household survey we're including questions about what kind of health-seeking behavior patients have before when they are bitten by snakes. And you can also see that they do use traditional methods and sometimes visit traditional healers. Ben, do you want to talk about the community?
Yeah, sure. I mean, exactly. I think we have seen some, and just mentioning also about the traditional healers. There's definitely a lot of insight from, as Gaby mentioned as well, in the focus group discussions on the use of traditional healers. And I think it's important to also to know that because snakebite has such little resources and lack of capacity, a lot of the reasons why people are going to traditional healers is because they don't have any other alternative. And because if they go to their health facilities, often there'll be no services, no healthcare workers trained often, and anti-venom is often not available on other commodities. So, it's really important to, as part of community engagement, to be engaging as well with traditional healers and providing them with the right sort of information and the right sort of guidance and support, so that people with snake bites are getting the help they need. But as well, not just in communities, that healthcare workers are trained and given some capacity as well. Because if people start going to health facilities and there's nothing there, you've lost their trust, and it's going to be even harder to get them to go back again. So I think it's really important that community engagement and education is done in a way integrated with work and capacity built in health systems.
Absolutely, that's a very good point. Very important. There's been a bit of a curiosity on the chat function amongst our attendees. You mentioned the black stone. Some of us haven't heard of it before. Would you mind to just give us a few words about this?
Do you want to, Gaby? Or?
Yeah, you can go ahead as well.
Yeah, sure. So the black stone is from what I've seen, is often used in sub-Saharan Africa. It might be in other regions of the world as well. But it's literally just a small, usually small piece of coal or a stone itself. And this is essentially, it's seen by traditional healers, and as a traditional method, it's used in a way which tells people with a snake bite that if they put it over the wound, that it will suck out and distract the venom from within the body. So it's seen as a method used just after a snake bite to stop people from getting bad envenomation. And there's very little evidence to support its efficacy. And I would definitely recommend not using black stones or any other sort of such traditional treatments like them at all.
Okay, noted. Thank you for that.
Just to add to that, actually, what makes it more complicated is that not all snakes are venomous. So often, for example, a traditional healer will get someone who's been bitten by a snake, and that snake's not venomous. So using the black stone will be effective because there was no envenomation in the first place. So it's very important to get very clear and concise guidance at a community level and to traditional healers, to really debunk these myths.
That is a very good point, absolutely. Moving on a little bit to sort of the surveillance aspect of the snakes themselves, we have here a question from Amadou Wuri Jallo. Amadou is a WHO TDR fellow and currently at the Royal Veterinary College, the RVC here in the UK. Hello, neighbor. Hello, Amadou. So Amadou was just asking, saying that the Gambia uses the IDSR, Integrated Disease Surveillance and Response Technical Guidelines, and therefore snakebite is now included in our surveillance weekly reports. However, the investigation during the surveillance can prove difficult because most of the time the snakes are hardly seen or difficult to distinguish in terms of types of snakes to help with treatment. What might be your best advice to improve the situation to ensure proper investigation for appropriate intervention?
Yeah, I mean, I think that from my perspective, I think it's really important to do some of the research, comprehensive research, to really back up areas where surveillance is showing that there might be some snake bites, and if the information isn't adequate coming through that, I think it's really important to have research. Some of the things like Gaby has mentioned. And also at a community level, so that we can really collectively understand a bit better, contextualize for those countries, what are some of the key indicators which are needed to pick up, the right sort of data and to kind of deal with those issues. And the WHO have been working on, looking at standardized indicators at a community level. And I think as well at health systems level. So hopefully WHO guidance in the future can support those sort of problems as well.
Absolutely, Gaby, would you like to add to that?
No, I think Ben covers it here.
Yeah. So a few questions we're looking at the detail of the research you undertook. We have here a question from Jacqueline Mutimba. Hi, Jacqueline. Thank you for your question. What explains the increase in snake bites in Uganda in April, June, and October to December?
So we compared it to the weather patterns, and what we found is that it's in line with the rainy season, similar to what we found in Zambia, that in October, November, and November, December, and January, when there's the rainy season in Zambia, there was also an increase, according to healthcare workers, in snakebite patients that they saw at the health facility.
Great, thank you. Robert Rono is asking, was the type of antivenom available asked?
Yeah, so we also asked about the brands of the antivenom, and we found, I think, Ben, you know the specific names of the antivenom? Yeah,
so I think depending on the country, I think an Indian product called Vins was quite prevalent within Kenya, Uganda, and Zambia, which is a product often found. And then I think that there was also Inasan, which Inasan is a manufacturer which produces a product. I think it's called Inaserp, specifically for neurotoxic bites. And that then also there will be a South African manufacturer called SAVP who produce a product which is more expensive, but it has quite strong efficacy, and that is often, I think, available more in the private sector rather than in the public sector, currently at least.
Right, brilliant. Another question as well, are you thinking of perhaps expanding your research to including different additional countries or perhaps wider regions?
Yeah, I think we are for sure interested in expanding to other countries as well, trying to support governments in tackling snakebite. Of course, we're an NGO, so we're always dependent on funding as well. But it's for sure an interest of us, and we would love to expand our program.
Yeah, I mean, it's really down to resources. We would love to work in more and more countries, and we get a lot of responses from ministries of health and different stakeholders to work more at a wider scale, and mainly it's down to resources, to be honest. But we do really want to receive and build communication as well, and there are certain steps maybe that we can provide to support. At least at a kind of an early stage to stakeholders or communities or ministries of health to at least get things moving in countries and start to build towards bigger programs in the future.
Absolutely. And on the topic of funding, of course, this is a persistent and quite significant challenge for many working in the field of snakebite. Just wanting to flag that my colleague Cameron Rafiq has put on the chat a link to some Wellcome Trust funding available specifically for snakebite programs. You may have seen as well, last week we had a ISNTD Connect webinar from the ASCEND team. So this is a DFID-funded fund, DFID organized fund that is looking at supporting innovation and learning within NTD. So perhaps again another place to find some more funding. There's also an NTD Innovation Fund open at the moment. So quite a few opportunities for funding if anyone in our attendees or yourselves are looking for this. And if you missed that Ascend webinar, just a reminder that it is available on our YouTube channel, and there's lots of information and detail there. So that was just kind of an aside. Just coming back to a few of the questions on your research, we had a question here from Helen Nyakundi. The commodities research did not cover Kenya, and Helen was wondering what might be the reason.
Yeah, so it was on the planning for spring this year, but of course, due to the COVID-19 situation, we couldn't do the data collection. But we've postponed it, and we hope to do it when the situation allows it again. So yeah, we're planning to have information on the availability and affordability of commodities in Kenya as well.
Brilliant, that makes sense, thank you. A question here about perhaps looking at partnerships or, kind of bringing in other sectors into the snakebite, tackling snakebite. A question from a comment from Blessing Jiwa, who's highlighting that what about prevention, considering that snakes are important for pest control? So in one sense, they do have a role to play, and are there any programs in place to prevent snake bites amongst farmers and around households? And building on that, we also had a comment from Emmanuel Agunoye saying that snake bites affect mostly farmers, and snake venom are mostly enzyme toxins and dangerous microbes. And Emmanuel's comment was just that there must be a collaboration between WHO and FAO before any major breakthroughs can happen in cheap anti-snake venom drugs, since this is not an elite problem. So I think both those comments and questions really asking, can more be done since the main victims are farmers? What partnerships or what sort of communication channels could be done, focusing a lot more on the farmers?
Yeah, I mean, it's a good point. I mean, some of our materials, and there are others, I think you can see on the link, my colleague Beata mentioned, you can check out some of our tools. We're constantly looking to update and provide more resources around prevention. We do have a poster, a leaflet, for example, which does provide some really important messages, which has been in consultation with communities themselves, which really look at prevention and making sure that basic messages are provided at a community level to reduce the likelihood of snake bites in the first place. I think it's a really good point that we cannot, you sometimes hear, for example, why don't we just kill all snakes? and snakes are an integral part of our ecosystem, and like it was said, you know, they also kill rodents and are an important part of you know, part of our habitat. So I think that it's really important that the right messages are found, because you do often get people that will try to kill the snake, and in the attempt to kill the snake, they'll get bitten themselves. And sometimes it's seen as well that you have to kill the snake and take it with you to the health facility so that they can ID the snake itself, which is really dangerous. And even when the snake is dead, you can still be bitten by it if you are to touch its fang, and there's venom still in the fang. So, you know, these sort of things are really important, and that the right sort of messages are in place. You know, I think the WHO and the FAO, I don't know specifics on that and whether there's been any communication, but I think, you know, it's been fantastic that the Wellcome Trust, for example, have come to the table to work on treatments and provide resources within that space. And I think that it's very important that, you know, community engagement and messages and interventions at health facilities and all the way down to the ground are also supported, and resources are there as well for policymakers to integrate snakebite policies. So I think that's encouraging, but you know, I think it's also important that other donors come to the table, and that we do see more resources as well from ministries of health themselves, you know, to kickstart snakebite programs and look for other collaborations, you know, necessary to deal with snakebite.
Fantastic. And you were kind of mentioning now moving on to the policy arena. A few comments were here in the chat, and we're speaking about, for example, the cost of antivenoms and how you know, stakeholders could come together, also civic society, and governments and so forth, to perhaps with a common voice stand to bring those costs down. Dr. Obiageli Nebe was asking, sorry, I've just lost the question on the chat. Oh yeah, so the first question from Robert Rono, sorry, are there any strategies to support African countries to manufacture country-specific anti-venom? And would that also perhaps help to alleviate some of the supply issues in terms of cost and just quantities of venom available?
Yeah, I mean, I think for that question, it's important to understand, you know, the WHO roadmap really outlines some important steps around, you know, improving the current state of treatments. They have a pre-qualification program which essentially looks to evaluate different antivenoms and provide pre-qualification status to provide support to ministries of health, so that they have better understanding of what antivenoms you know, they can look to use in countries, and which are recommended not to use. Sorry to say, just to go back on that, it's only on recommendations of what to use, and doesn't provide recommendations of what not to use, but still gives more guidance to the ministries of health themselves if they want to, you know, in the future provide more clear guidance on what they can use for antivenoms. And of course, antivenoms themselves, you know, it needs more resources, and they need more scaling up so that manufacturing capabilities of current good antivenoms are expanded. So I think that's a very important point, and that regulations are better in place with guidance from the WHO to support, you know, wider treatment programs for snakebite. So I think those are integral things, and I think manufacturing, you know, definitely that is something for the future, and I think it's good if governments are taking potentially steps towards that. Of course, it needs a lot of investment, and if there is investment to work towards that, that's definitely a good thing for the future. And you know, for example, manufacturing on a more of a regional level, where a lot of the snake species are more similar across you know, neighboring countries, can really provide more of a market and better demand for for anti-venom products. So I think that's definitely a good move, but I think we're still a bit away from that, at least now.
Right. Ben, Gaby, we're coming up sort of towards the end of the time allocated for our webinar today. There are still a huge number of questions and comments outstanding on our chat. I think you've you've given us much food for thought. One of the sort of remaining questions was for perhaps some of our colleagues who have joined today who aren't necessarily immediately experts. They were just wondering what might be some of your recommended sources of information, or where could they find out a little bit more about the burden of snakebite worldwide?
Gaby, do you want to?
Yeah, I think there's quite a lot of information on the WHO website just about numbers in general. You can also find some fact sheets on our website, highweb.org, specifically for Kenya, Uganda, and Zambia. For the research we've done, we're also publishing reports on it, as well as scientific articles. But I think for just background information in general, the WHO has a very good website. So I would refer them onto that. And there's also information on our website.
Yeah.
Great. And we thought perhaps to round off the session and to kind of build up on what you were saying, a few years ago, a very poignant documentary came out, a film called Minutes to Die, which charts very comprehensively the whole range of issues in and around snakebite, from its impact on very vulnerable communities, all the way to the R&D needed and some of the gaps. And so we thought this would be a great time to perhaps show the trailer to our attendees to kind of round off the session. So if you don't mind, I will just play that now. And perhaps following the trailer, we could hear from both of you what might be your thoughts, and in an ideal world, what would you like to see as next steps for snakebite? But for the time being, I'll just play this trailer. It's about 2 minutes long.
We've seen death. We've seen disability.
Being a victim, I've endured unbearable suffering.
We've seen disfigurement.
Crisis is a good word for what's happening at the moment.
Most victims of snakebite are amongst the most impoverished levels of the community.
I'm only asking God and wonder why this had to happen.
It's a cobra. Okay, so the people raising their hands have been bitten by snake.
This is the reason why people get bitten by snakes all the time. Bare feet, bare feet.
Snakebite is the most neglected of all the so-called neglected tropical diseases.
So he sold 25 goats to buy the treatment for his kids, and now he has no source of income.
This is the only one left?
Mm-hmm. The platform for providing these antivenoms has collapsed.
Those who are manufacturing the antivenom are backing off.
If we are to save lives and limbs, this is the time for the whole world to wake up.
It's probably the best chance we're going to have to get snakebite properly on the world's radar.
Can you imagine some poor little African child with that happening?
The world has the capacity to deal with these problems.
Complete victory.
Getting this drug is a human right. It's not a matter of economic business.
Can you imagine the distress of running from your home, perhaps in the night, with a child on your back, suffering from snakebite, screaming in pain?
That's just a small trailer from the film Minutes to Die. It's you know, very moving full-length feature as well. And some of you have asked where you can see this, access this trailer, and as well as the whole film. And they are both available on YouTube as well as on the Minutes to Die website. There are still a huge amount of questions and discussions that are ongoing on the chat. Gaby and Ben, I think you will have your inboxes quite full by the end of the day. Your colleague Berta has put on the chat function your email, direct email. So to all the attendees, like to follow up, by all means, please do get in touch. I am sorry that our time has run out, because this has possibly been one of the most kind of active discussions. Clearly, the snakebite community is just raring to come together and move this forward. If anybody would also like to watch again this particular webinar, as well as all our previous sessions, as I said, please do jump over to our YouTube channel and subscribe. You will get every single update and also access to all our past sessions. So don't forget to go to our YouTube channel for this. Finally, as a kind of few words of conclusions, Gaby and Ben, we would be interested to hear perhaps your thoughts on what you would like to see happen next, maybe which partnerships or which innovations you'd like to see to facilitate your work, and also the tackling of snakebite and snakebite envenoming worldwide.
Yeah, can I'll just also put our contact information on the up on the, let's see, yeah, so you can contact Ben or I. It might be easier than trying to find it back in the chat.
Great.
I think just to start with what I would love to say, I would love to continue working with governments to try to make the commodities necessary to treat snakebite available. So working together to ensure that antivenom is available in the country, but also trying to improve the surveillance and monitoring systems in health facilities and throughout the supply chain, trying to make it more efficient to ensure there's also no stockouts. I think that's a step I would love to work on with governments.
Yeah, I mean, just to add to that, really, I mean, for me, I think, of course, research is so integral, and particularly, you know, from the community research that we've been putting together, I think it really ties in how important, you know, gathering more, you know, research really is in more countries. I mean, for example, Zambia and Uganda have barely had any publications or research at all on snakebite, and that's just not acceptable when we clearly see in both of those countries that, you know, snakebite is a big problem. It's just hidden within communities, and so on that note, I think what's also just really important with research is really engaging more with the communities. So whether that's you know, providing them their voice more on the global fora, you know, to discuss their experiences and what interventions and what actions they would like to see to manage snake bites, you know, in their own communities, I think is an integral thing. But also, as I mentioned before, that we start to really bring together these models of best practice for snake bite, which are happening in communities all around the world, and that we really use that as a good blueprint to develop policies, you know, to sustainably deal with snake bite at a community level and wider afield.
Fantastic. Thank you very much. On those words, you've given us much food for thought. Thank you so much, Gaby and Ben. I'd also like to give a very big thank you to Berta Bogatz, also from HAI, with who we worked to put this session together. So to the three of you and to the whole team at Health Action International, a very big thank you. Thank you also to all our attendees, everyone who joined today. Please feel free to continue the conversation on the chat for the time being, and don't forget to be in touch with Gaby, Ben, or myself if you would like any further information, whether it be about the current research and also the Minutes to Die documentary, or more generally our ISNTD Connect series. So on that note, I'd like to wish everybody well, keep healthy and keep safe. And we look forward to seeing you again next week, Tuesday and Thursday. Gaby, Ben, thank you so much. And let's keep in touch.
Yeah, and thank you so much for having us.
Thank you very much.
Bye.
Take care, everyone. Bye-bye. Bye.